going to talk now about a couple of projects coming up in the next year, which I hope will be of value within the region. We're definitely keen to connect where possible. So just to put it on your radar and explore opportunities for synergy there. They basically have two different foci, one at the kind of organizational level, thinking about readiness for AI, and another at an individual level, so it's kind of program of learning education. So last time we were here, which was great, back in May, I spoke a little bit about a project I've been involved in the States back in 2022, a group called Health AI Partnership, who are trying to basically consolidate good practice, if you like, for AI implementation, or do their best to abstract some high-level takeaways. And that involved these kind of 8 steps across the AI life cycle, which will look really familiar to other areas of digital transformation, going basically from a problem first to thinking about solutions and matching them, some stages of evaluation, implementation, and having a view to the sort of end of the life cycle. The challenge here is that the US is very different to the UK, and you can get kind of insights from this, but it's not necessarily that easy to translate it directly. And so that's what the first package of work I want to talk about is. It's basically a follow-on, if you like, from the buyer's guide from 2020. The work's called the AI Readiness Checklist. That's what we're trying to build, if you like, for an NHS-specific setting. And I'll tell you a little bit more about that now. And it's funded by the NHSE and the Health Foundation. So this is a little kind of schematic, which is just drawn from kind of experiences across the UK and US, trying to put some flesh on the bones of this idea of AI readiness. Just thinking about the ways that governance of AI seems to occur in the wild, if you like. And you see examples at the top at sort of maturity level 1, if you like, where essentially AI might get over the line simply by a very energized clinician champion coming to a trust that doesn't have experience of before and finding their own way, rightly or wrongly, through different decision makers at different levels of the organization. Moving down to the next rung, the precedent-led decentralized governance, which needs a better title, but hopefully conveys the idea that basically this is a second or third enthused clinical champion that experiences slightly less resistance because somebody's done it before and they've got a path to follow, and perhaps that is slightly easier for them, rightly or wrongly again. Then you often see a kind of acknowledgement that there should be some centralization of this responsibility within an organization. So some kind of group or part of the governance structure takes AI within its portfolio, but sometimes the kind of expertise or capacity required to run the kind of evaluations and generate relevant evidence isn't necessarily there. And then the final stage that you can see in places, certainly in the US, there are some examples of a kind of proactive centralized governance. So they've got this advantage, just like at stage 3, where there's a kind of central function within the trust. So there's oversight of what's going on, but there's been a proactive consideration, calculation of what resources required, what the capacity of that would be if it's resource limited, and those kind of things. So thinking a bit more about this idea of AI readiness, how can low AI readiness cause harm? Well, I think the thing that you see most often, which probably alludes to what you're saying, Tanya, about people advocating for shiny new AI things, is probably suboptimal investment of scarce resource. If things are kind of promoted actively because they're new and shiny, and the time isn't spent to kind of drill down into what the evidence is and what the likely return on investment is and that kind of thing. So you can see implementation of unsuitable AI technologies. That may be because the use statement, for instance, that they're regulated against doesn't actually fit with the need. There may be a failure to identify new risks emerging over time. So one of the hallmarks of AI technologies is this tendency to drift, and a degree of responsibility has to lie at the provider level rather than the vendor level to monitor for those risks as they emerge. And then another one to consider is a kind of reputational damage, that kind of trust in AI innovation, which may affect appetite for future AI innovation. And even from the manufacturer perspective, certain products, if implemented inappropriately or have harms that may not have occurred in stronger governance systems, may limit sort of downstream benefits. So to come to what the AI readiness checklist is, the aim is really just to kind of surface good practices around AI implementation, think about what organizational capabilities are required to enact those practices, and hopefully promote safe, effective, equitable AI innovation in the NHS that way. We see that being useful as an intervention for staff to see what changes may be beneficial within their own setting, hopefully act as a bit of a safety net when trusts consider whether or not they are prepared to take on AI innovation, and promote consistency across different trusts. That certainly has a big impact from the vendor perspective when they're trying to scale innovation between different sites. At this stage, primary and social care feels like too big a scope to try and address with the single intervention, but we're also bringing representatives from primary and social care into the conversation to start to think about how it might translate. So to give you a sense of what's coming up, we'll be kicking this off soon. Essentially starts with a phase of desk research and 1 or 2 interviews to draft a checklist, which will then take into a kind of refinement stage with a workshop and focus groups with representatives at different trusts to see what they think about it, what could work better, what doesn't work so well. And then a final stage where we're hoping to run with a few different partner sites, piloting the readiness checklist as trusts interact with it and think about how it affects their thinking around governance structures and implementation of it. I'm going to skip forward through a few slides just to make sure I get onto the second bit. But just to say, opportunities for engagement. One of the roles we have, just to draw your attention to this on the right-hand side, because it was just published yesterday in the NHR-supported Incubator for AI and Digital Health, which we host here at UHB, with a secretariat for ADAS, which is the AI and Digital Regulation Service, if I haven't crammed too many acronyms into 1 minute of speech. But they've recently just published this case study of a trust in Frimley as they established their AI governance framework, which makes for an interesting read. But it's also a super helpful resource in this space, basically providing guidance straight from the horse's mouth from NICE, MHRA, HRA, about how to do this well. So essentially, there are opportunities for engagement coming down the line. So you may hear from me in the future, or if you want to reach out for any of these, and it'd be great to hear from you around essentially evaluating the checklist and potentially even. But I'll pivot now onto the individual readiness, talking about training. There was a workforce report from what was the AI Lab and Health Education England in 2022, now all various parts of the NHSE, that considered what kind of training needs the NHS workforce has around AI. And there were kind of 3 frameworks that came out. There's this 3-step thing about the depth of learning, from educational groundwork to foundational AI and product-specific training. And they also produced 5 different archetypes, is what they call them. So the kind of roles, 5 different roles that healthcare professionals may play around AI. But for me, the kind of 3 groups, if you like, to simplify it even further, was that everybody will need a foundational understanding of AI, perhaps to field questions from patients and to anticipate some of the risks. Many people will come to work within healthcare pathways that involve AI, so they may well need an operational understanding so they can basically spot what errors look like and understand how to escalate them, not necessarily deal with them themselves. And then there's this final category for some for individuals that lead the innovation efforts, workforce champions that have kind of T-shaped expertise, if you like. So they have their deep expertise in whatever their role may be, as a clinician perhaps, but then this kind of foot-deep, mile-wide expertise across the AI lifecycle. So they know different parts of the organization to connect with at different stages and kind of line up efficient activity. And that's a group that was called embedders. When I mentioned these 5 archetypes, there was one from the report called an embedder. And it was particularly targeted as a group that isn't that well represented within the workforce at the moment, but a kind of rate limiting step, if you like, because I didn't go into the slide in the end, but if you think about the timing of any kind of digital transformation, but particularly these AI innovation efforts, this clinical champion may have an idea 3 years prior to the AI workflow actually beginning. So if you think which of the expertise most urgently needed, if you like, to support responsible AI innovation, that's certainly high among them. So to try and address that, hopefully, I say hopefully because I'm submitting the final revised proposal for Friday, we'll be launching an MSc in AI implementation at University of Birmingham from 25 to 26. It's served pretty flexibly, can be as an MSc, but also many of the modules are delivered as 1-week intensive teaching blocks, which are kind of micro-credentials, which I'll come into in a minute. So the reason I wanted to put this on your radar is first to think in advance if these graduates or people with these expertise might find a place in the workforce of trusts in the region, if there's any kind of opportunities we should be aiming for as we shape the materials. And the second is that these micro-credential modules are designed very much with mid-career professionals in mind. So if it is an opportunity that fits for any members of your workforce, it'd be good to put it on your radar that way. So the titles of these micro-credential courses are Key Concepts for AI-Enabled Practice. So the idea of this is basically not to have any mathematical or coding requirements, but understand what the risks are with different AI health technologies, what the benefits are, what they're good for, what they're not good for. So kind of conceptual understanding of the products. Quality assurance for healthcare technology is an understanding of the regulatory landscape as it relates to AI and helping to navigate some of that from a due diligence point of view. And then evaluation and governance of AI in healthcare has a focus more on creating the kind of evidence that we're speaking about locally and evaluating evidence that's been produced elsewhere. This is how the whole MSc stacks together, but you'll see those 3 courses and how they sit across the year just as standalone weeks. And for graduates that do the full program, there's also some public health modules around health economics, commissioning and other aspects, give a bit more of a holistic overview. The dissertation project focuses on taking a clinical need, identifying regulated AI products, and basically building a value proposition to put forward to decision makers in a kind of mock scenario. But the point is, it's very practice oriented. So the reason I've been telling you all about that basically is, as I mentioned, just to see if these things sound useful, if there's any particular workforce gaps it might help to fit. And yeah, also in terms of the problems that we set in the curriculum, it'd be interesting to hear now or later if there are any recurrent pain points or questions that come up that would be interesting to dig into. So I'll stop sharing